This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I bring you my conversation with Dr. Christian Barton, where we delve into the assessment and treatment of patellofemoral pain. In our discussion, Christian will cover differential diagnosis for patellofemoral osteoarthritis, patellofemoral pain, and patellar tendinopathy, and key risk factors, the best practices for the assessment and treatment of patellofemoral pain, insights into running retraining, and much more. Dr. Barton is an associate professor at Trobe University and a clinician specializing in knee pain and running-related injuries. He leads significant projects to improve access to exercise and education for osteoarthritis and translates research into practical treatment approaches. He also serves as an editor for the British Journal of Sports Medicine and is an internationally recognized speaker and educator. If you find our conversation informative, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who might benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer.
Welcome, PT Pro Talk listeners. Looking to enhance your rehabilitation practice or promote active aging? Urban Polling Inc. has you covered with our evidence-based activator polls and program, trusted by over 10,000 therapists worldwide. These unique polls, designed by an occupational therapist, improve stability, posture, and mobility for individuals with conditions like Parkinson's, stroke, arthritis, and ortho rehab. Visit urbanpolling.com/PTProTalk and enjoy an exclusive 30% off on CEU-approved courses and 20% off for activator polls. Hi, Christian. Welcome to PT Pro Talk. How are you today?
I'm good. Thanks very much for having me.
Awesome. So let's get started talking a little bit about yourself and your background for the ones that don't know you.
Yeah, sure. So I'm a physiotherapist working in Melbourne in Australia. I practice clinically 2 days a week, seeing patients, a range of mostly lower limb, so knee and tendon injuries particularly. And that ranges from adolescents to older people, really sedentary people through to really elite athletes. I see a big variety. Outside of my clinical practice, complete in Richmond, I work at Trobe University, so I'm an associate professor in physiotherapy there, and I do a mixture of teaching and research, just a little bit of teaching and more research, and my research is these days mostly around what we call implementation science. So rather than just trying to research new exercise programs and treatments, but actually thinking about how we can translate those into real-world clinical practice. And being a physio, obviously, with a big focus on how do we get physios to adopt what we know is evidence-based practice. So that takes up a fair bit of my time. And then I do a little bit of teaching of private courses around the world, of teaching running injury courses and knee pain courses as well.
Awesome. And is that the track that I saw that you were the founder?
Yeah, so there's a few implementation projects I work in knee pain space, in low back pain, even in cancer rehab, a whole range of different things. Trek's a not-for-profit initiative that we established around 2016, and it was actually while I was studying a communications master's degree, thinking about how do we translate information to consumers and people who might use it. So both clinicians and also the general public, and my focus being musculoskeletal pain. And we set up Initiative TREK, which stands for Translating Research, Evidence and Knowledge, and it's a multi-site platform. So if you want to check it out, it's trekeducation.org. And on that, there's sites about how to manage patellofemoral pain, how to manage knee osteoarthritis, low back pain, even cancer rehab, which I mentioned before. We also have developed some sites for patients, so people who have got patellofemoral pain and knee osteoarthritis, and we have a few others in the works which aren't published online yet, and around heel pain and other conditions. And the whole purpose of the sites is to provide evidence-based information in easy to digest formats. So think of your blogs, type writing, but also infographics, multimedia resources like a video, exercise videos, podcasts like what we're doing here, which are interesting. So the whole idea of just meeting those who want the information with a type of resource that they're actually going to engage with, rather than having it all trapped in research papers, which no one can access, or even if they can access it, most people don't understand what's being written in them either.
Okay, and when you say translate, you mean helping to digest the information, not literal translation in different languages, right?
So there is we do have some resources. So I have a big focus on the whole translation of research into practice. And so there are some resources where we do have translated into different languages. But yeah, okay. I guess the meaning of translation in this instance is translating into clinical practice.
Yeah.
But part of that can be actually translating to different language. So some of the research I do in my implementation science work is with cultural linguistic diverse populations. And we have, I think in a study of a few hundred people here in Melbourne with knee osteoarthritis, there's about 30 odd different languages that we need to cater for. And so we do try and work to translate some of the resources into different languages.
Very cool. Okay. And now talking about knee pain. So differential diagnosis. So how do you differentiate between patellofemoral pain, patellofemoral osteoarthritis, patellar tendinopathy?
Yeah, sure. So I think if we sort of talk about patellofemoral pain and patellofemoral osteoarthritis, I think they're most likely on a continuum. So I don't know that you're differentiating between those two. I think the definition of osteoarthritis, we can look at structural things. So you might look at imaging, might help you a little bit with that. But we know most imaging findings aren't related to symptoms anyway. So you might have structural signs of osteoarthritis in the kneecap or the patellofemoral joint and have no pain, or you might have pain. So I wouldn't try and differentiate between patellofemoral pain and patellofemoral osteoarthritis. I'd keep them pretty much on a continuum. But if we look at other pathologies of anterior knee pain, the common ones that might either coexist or be a differential diagnosis are tendinopathy, as you mentioned. There might also be fat pad irritation, and there's a few other things. But if we talk about tendinopathy, one of the key ones, your patient history is really important. So a tendinopathy which is irritable, is usually going to be on the background of doing high impact, high rate of force development type exercises. So would be from sprinting, but particularly jumping, those sorts of activities, basketball, and would have been quite a recent flare-up of symptoms. In long-standing pain, it probably starts to make you think a little bit more about patellofemoral pain. Clinically, if you want to differentially diagnose a little bit the source of symptoms, so palpation. So if you palpate the inferior pole of the patella, and that's really tender, there's a good chance that there's a patellar tendinopathy at play, especially if it fits with your clinical background. And then what flares the symptom? So I often find doing resisted contraction of the quadriceps, whether that be doing manual muscle testing or handheld dynamometry or even in a leg extension machine, and what range that's painful in can be quite diagnostic. So if you have patellar tendinopathy, you typically won't get a lot of symptoms in terminal extension. So as you go towards the last 30 degrees or so of terminal extension, so with a straighter knee. Whereas if you go to a deeper knee position, which puts a little bit more compression and tensile load through the tendon, that'll typically be quite painful with a patellar tendinopathy. In a patellofemoral pain situation, you'll usually find that last 30 degrees or so is the most symptomatic period. So as your knee straightens and you load up the quads, that's where it'll often be symptomatic. And there's a couple of reasons for that. One of the key ones is that the patella is its most unstable through that range. So if you're getting any issues with lateral tracking, for example, that will occur more so in terminal extension. And there's good MRI studies that compare people with and without patellofemoral pain that show that. And that will usually be where it's symptomatic. And as you go really towards terminal extension, you often will get irritation of fat pad there as well. So you get a lot of compressive forces going through the fat pad. So if you're sort of thinking tendinopathy, but then you've got most of your pain in terminal extension, it may not actually be the patellar tendon that's at play. It might also be fat pad irritation. So that's the kind of things I'd go through with differential diagnosis. And then, of course, we want to be screening for meniscal pathologies and doing torsional tests like McMurray's, sometimes pes answering bursa irritation, and that's really difficult to diagnose clinically, but they may have pain during that resisted contraction, and often an ultrasound or something like that to see if there's any inflammation in that bursa can be helpful. The other really helpful way to differentially diagnose patellofemoral symptoms and what you might do clinically is to do a treatment direction test and give the patella some support and see if you actually hold it so it doesn't translate so far laterally. If that helps their symptoms, to me, that's quite diagnostics that you've got a patellofemoral issue. And of course, you could try some taping as well, which can be diagnostic too.
Mm-hmm. And regarding the squat, any difference on their patterns if it's patellar tendinopathy or patellofemoral pain?
I think in a patella tendon, a squatting activity is not usually painful or provocative because there's just not that high a load going through the tendon, unless it's a really irritable tendon, then a squat might be painful. Whereas patellofemoral pain, in most cases, a single leg squat, for example, would be symptomatic. I know from our research, I think it was about 85 to 90% of people with patellofemoral pain, a single leg squat would be symptomatic. So I don't think you want to rely on one test. I think you sort of got to put together a few different tests. A tendon would be more symptomatic with a jumping activity, whereas, I think patellofemoral pain will be more symptomatic with lower level tasks typically.
Okay. And in terms of like osteoarthritis, you're saying that you're not trying to differentiate per se. Like in the level like stiffness, regarding stiffness, do you see any difference between the two?
Yeah, so I guess if you talk about the continuum of patellofemoral pain, you might have a patient who's an adolescent, so they're not probably going to have osteoarthritis. They're young. Symptom duration is quite short. Someone who might have osteoarthritis, we're thinking more of a clinical diagnosis. So it's a long duration of symptoms. It's not just pain, it is stiffness like you're talking about. So a clinical diagnosis of osteoarthritis is typically that stiffness first thing in the morning. That might last up to 30 minutes. If it's lasting longer than 30 minutes, then you probably want to think about systemic things. So maybe there's something rheumatological going on or something else going on beyond osteoarthritis, but that stiffness is a key differentiator. And then age of the person as well is something to consider, and or history, because we see someone who's had a post-traumatic knee injury, for example. So a lot of my clinical practice and research is in the ACL space, and we see, depending on how you diagnose it, but you might see upward of 50% of people within that first 5 years or so would have signs of patellofemoral osteoarthritis after an ACL injury. And these people are typically maybe in their late 20s, early 30s, sometimes even early 20s, depending how young they were when they tore their ACL.
Mm-hmm. And in terms of treatment, I know I'm jumping ahead just a little bit. We're talking about the differentiation. Do you treat any different osteoarthritis and patellofemoral pain?
Not really. Probably just being mindful of the stiffness you mentioned before. So if someone is really stiff, then sometimes patellofemoral stiffness is not usually a key factor, can be. So you may consider mobilization of the joint, but it's rare that I would do that. Typically what I'm looking for with stiffness in someone who's got more osteoarthritis symptoms would be lack of knee extension, because when you struggle with knee extension, that can start to cause a lot of issues around loading of the patellofemoral joint. So if you're always in slight flexion, your joint's always under load. So I may look at doing some tibiofemoral mobs, and I'll usually do that in the clinic and see if I can improve their range of motion into extension, and that's usually quite therapeutic. And then I try and teach the person how to do these things themselves, because you can typically teach them how to do it yourself. And then the other thing, if they've got osteoarthritis and or a long duration of symptoms, we know that that's very prognostic, as in the longer symptom duration, the less likely you are to recover. And so it's probably then how you educate the person and managing their expectations and how patient you might need to be with the rehab and how long it's going to take. So you might talk to someone with long-term symptoms and more signs of osteoarthritis and say, look, we're going to get you better, but you've got to do X, Y, and Z, and you really need to buy in and work at this rehab for at least 12 months or a couple of years, and you'll keep improving over that time. Whereas an adolescent with patellofemoral pain who's only had it for a month, we probably don't even need to do rehab. We probably just need to talk to them about all the sports they're doing and the fact that they're doing more than their favourite elite athlete. And they probably need to back off how much they're doing, and their pain should go away, and should go away quickly as long as they manage their loads a bit better.
Mm-hmm. And risk factors associated with patellofemoral pain. So I was listening to you talking, and people always ask about the hip, like if you have hip weaknesses, if that's a risk factor And then I saw that you said that it's not, that it's kind of the opposite, is a consequence of patellofemoral pain, right?
Yeah.
So like risk factors, anything that we know about what could be causing the patellofemoral pain or be a risk of?
It's really not very clear at all. So if you talk about the hip, which is the common thing people go to, when we've published a couple of systematic reviews with different groups I work with around the world. So David Bassett-Jones just led a systematic review looking at running and walking kinematics, and we really don't see any differences at the hip that might drive patellofemoral pain development, and or even a lot of differences once someone has patellofemoral pain with those activities. Maybe squatting and jumping and landing, there might be a different story. And the hip strength you mentioned, well, we see once you have pain for a period of time, you develop hip muscle weakness, and that's really clear, and reduced rate of force development, which I'm sure we'll touch on a little bit later. But is that a risk factor for developing it? So if you were to screen a group of your basketball team or soccer team or running population, would you identify those more likely to develop pain or not? The answer to that is no. And in fact, in a couple of college studies that I'm aware of for basketball, for example, in females, is that actually higher hip strength seems to be related to greater risk of developing patellofemoral pain, which is really quite interesting. And then if you look at things like foot mechanics, there's a little bit of research that looks at that, and maybe there is some slight differences in how the foot moves and slight differences in foot mobility. But we're talking, for example, of foot pronation measure that you might look at navicular drop. So those not familiar with that, you put your foot in a subtalar joint neutral position, which is kind of podiatry witchcraft of making the foot in a neutral spot. And then you measure how high the navicular is from the ground, and then you let the foot relax and you measure it again. There's a difference from a military study of 1 millimeter between those who do and don't develop pain. So can you measure that clinically? Probably not. A lot of people consider load as a really key risk factor, but we really don't have the evidence there to support that that is the case. We don't have good research into psychological factors or sleep or diet or all these other things. So I think what it comes down to is it's probably quite multifactorial as to why someone develops pain in the first place. And it might be psychological factors, it might be lifestyle factors like diet and sleep, or it might be some mechanics, or it might be strength, or it might be just they did too much too soon, or varying combinations of all those things. So if we're looking for the one or two things that are the keys, we don't really seem to find them when we do a research study. So I think you have to talk to each of your patients about their individual story, and you'll usually find some things to help their story make sense on an individual level, and that's important to touch on. So hopefully they can learn from that and hopefully reduce their risk of recurrence. But to say a blanket, this is how we need to stop patellofemoral pain from developing, I don't think we can do that.
Okay. And could you explain the patellofemoral pain impairment function-based classification subcategories?
So that's from the guideline I think you're referring to. So there's lots of different theoretical concepts around how to classify impairments around hypermobility, hypomobility, strength impairments, psychological factors. The classification system that's in the guideline, I would suggest, is not hugely valid, just to highlight. So I wasn't involved in the aspect of creating that for the guideline, and I don't know that I would, hang too much on it and use it too much. I think it's probably, again, comes back to that individual, because I know lots of my research colleagues around the world have been trying to look at subcategories and things like that of people with patellofemoral pain, and there's no good research I've found that actually would justify trying to put people into those boxes, and it comes back to the complexity of it. So apologies for those trying to apply that in clinical practice. I'm not sure it can be applied all that well.
I thought that was just interesting, like how they put like for overuse, and then some coordination problems, mobility. So it's just some things that we can think about maybe and look for.
I think that probably what it does, if you read through them, it probably gives you lots of factors to consider that might be part of the person's story in front of you. And some questions you can ask them and talk to them about, but you're probably not going to put them into any of those boxes.
And do you have any specific way that you go through like examination? So you were trying to identify if they have like a huge difference on load, or if they start running more, Do you check coordination, muscle strength, like you're saying? So how do you go about examining those patients?
Yeah, sure. So I think the first thing you need to do is do a really good subjective examination and get a really good understanding of their story. And if I break down what I'm looking for here, I really am trying to understand what were the key things that led up to developing their pain. And that could be a load thing. They've done too much too quickly, so they've suddenly spiked how much running volume they've done or exercise in general, or they've been doing extra in the gym. So thinking about that load perspective. I would also be looking for potential injuries in the past that might have linked to it. And it might not have been a knee injury, but maybe they had a traumatic ankle injury and they had a long period in a cam boot, for example. And then I talked to them a little about, did you do rehab? What did you do? And maybe they didn't do an adequate rehab of that in terms of restoring strength and muscle capacity. And so that could be part of what's led them to developing their symptoms. So that's looking at the real physical background and story. I want to know what other treatments they've done along the way. So that can be really important. So if they've had lots of passive treatment, for example, or they haven't bothered to manage it with any treatment, or they've done a good exercise program, or they've done an exercise program that they think is going to address strength impairments, but all they're doing is single leg squats the whole time. Looking for those things so I can understand where holes might be in their rehabilitation. So again, thinking about the physical part. But then I also want to know things around how they think and perceive their knee and their pain. So I'll ask them questions like, why do you think your knee hurts? And that's a really good thing to ask someone. And some people will talk to you about muscle impairments and things like that, or they'll talk to you about load, or they'll start talking about the structure of their knee. I found this on the MRI and I've got chondromalacia, and I have a great example from late last week. I saw a young adolescent girl who has femoral anteversion. And so she's absolutely convinced that her knees can't get better because she's got this internally rotated femurs. And so getting an understanding of what they believe might be the driver, because that will help guide things a little bit. Are they fearful that their cartilage is getting damaged every time they're doing exercise and loading it? Because we might need to give them some good education about not just load management, not doing too much. In some instances, that actually they need to load their joints and get themselves moving. So then also asking them questions. If I use adolescent as an example, how's school going? What do you like about school? What don't you like about school? Because if they've got a lot of anxiety and other things going on in their life, that could be a really big driver. We know there's links between anxiety and pain, and we see this in patellofemoral pain, and picking up on some of those things, because I might either look to refer them on or talk to the parents, or in an adult, how's work, how's other things in your life, getting an understanding of that. So that's really thinking about the psychological components of things, and that can be really important to address. For women, I'd also be asking questions about menstruation. So do they have a normal menstrual cycle? There's not a lot of research on this in patellofemoral pain, but we are seeing more and more emerging tendinopathy. And certainly we look at estrogen and progesterone, and they're protective against inflammation. And so we can see sort of two cohorts of women that this might affect. It might be perimenopausal, postmenopausal women, where they might get an increase in their pain, and that might be related to change in menstrual cycle. And in younger population, we can also see irregular periods, or women who become amenorrheic, and that can be really important. So sometimes picking up on those, which can be really tricky with an adolescent, especially when you're a male physio like myself, it can be quite tricky. So sometimes I gauge whether I can have that conversation with the girl in front of me, or do I need to talk to the parents and just flag it that could be something. And the more you ask these questions, the more you realize that they can actually play a really big role. And then the adolescent who I mentioned before, actually, that's probably a key thing linked to her condition, and she's actually going off to see her GP this week to get a few things looked at and sorted out, because she's been amenorrheic for, I think, about 6 or 7 months. And so that could be a key thing. And then leading on from that, thinking both men and women, general health, so sleep, diet, so having a real holistic look at things. Is there anything there that we can try and consider and address, and whether I can give some really simple guidance, or we refer on to a dietitian or to someone to help with some of their psychological stuff. So it's a lot of things to cover in an assessment, and to go into more detail, we'll probably have to talk through it for an hour now, and I think we want to cover some more things. But I think the short answer, if I go to a shorter answer, is be holistic and think about the physical things, both in terms of strength and also I didn't cover the objective part yet, but think about what they've done in the past around strength and those types of things and structural things that they might believe. Think about the psychological factors and think about general health factors, so thinking really holistically. If we move on to physical assessment, I'd go through some of the differential diagnosis stuff that we've already talked about. And then I'm really interested in going back to like what physical impairments may link to their pathology and thinking through not just structural things, but mobility. So is there any stiffness in the joint or hypermobility in the joint that we might need to consider? Muscle strength and muscle capacity. So I'm thinking about not just strength, the ability to generate force, but also rate of force development, which can be really important for people, especially if they're doing high level activity. So rate of force development being the ability to generate force quickly. Now that's hard to measure clinically. So if I wanted to measure strength, I might do a manual muscle test, or I might look at a handheld dynamometer, or I might look at doing a 10 rep max. We've got a gym, so I can do a 10 rep max of leg extension, leg curl, hip abduction, hip adduction, etc. Rate of force development you can measure a little bit with a handheld dynamometer. So that's something you can measure the hips. So I'm interested in those things and seeing if there's any impairments from side to side or just what I'd consider for general population. So without trying to lay down a whole list of things that would be considered normal, I'll use 10 RMs regularly, and I'd usually want someone to be able to get to, say, a leg extension of 50% of their body weight, leg curl of a third of their body weight, and I'll be looking at things like a 10 RM for heel raise, and for hip abduction, I'd want to be looking at sort of a fifth of their body weight, just as a general idea. So I'd test a lot of these things to see if there's some things where there might be some weakness. And in some people, you might pick up that they're actually really strong in their quads and they're really weak in their hip and their trunk. And so that will target what you might do exercise-wise, because someone who's really strong in their quads with an irritable knee, it's probably not much point giving them quad exercises. We probably want to really focus on hip strength. Whereas you might pick up someone else who actually their hip is okay, or there is a bit of weakness there, but their quadriceps are really, really weak. So we put them on the leg extension as an example, and we put it on 5 or 10 kilos and they really struggle with it. And that tells us we need to probably load it. We can talk through that a little bit more in a few minutes, I'm sure. I'll look at their biomechanics from a how they move perspective, and I'm not so much looking for gross abnormalities all the time. I don't often look at like a single leg squat, particularly these days, unless I'm seeing if I can modify their symptoms. So I might get them to do a squat, and then if I give them a little bit of femoral support, so I might give them some support on their femur, rotate a little bit laterally and see if that helps their symptoms. If that's helpful, then that guides me, doing some hip exercise might be helpful. Might do a little bit of support under their foot and see if that helps their symptoms. That might guide me to A, distal rehab, but B, probably thinking about simple shoe inserts might be really useful. But I'm not necessarily looking at trying to say correct that single leg squat movement and say this is how you need to move with that activity. I will do video analysis of running and jumping and landing and those sorts of activities, the things they find painful. And then I might give them some cues to change the way they move. So I do a lot of gait retraining in my clinic, so teaching people how to run differently. The primary thing I'm looking for is, can we change some things subtly and reduce their symptoms? And if we can, then I can try and coach them to do that and try and think about exercise to support it as well. So that's probably the key things to be looking at. So thinking about strength, flexibility, thinking about movement patterns a little bit. But mostly, if we change those movement patterns, does it help symptoms?
Mm-hmm. And I was just curious to ask about coordination. That was one of the things that they mentioned. Would that be on the biomechanics, or do you see anything like specific about like coordination?
So in terms of coordination, I think you can sort of look at a few things, I guess, and I wouldn't be pigeonholing people again, but maybe with their coordination, they may struggle with controlling the knee mechanics in terms of it's just not a smooth motion. So their knee is quite wobbly when you're watching them do activities. Mm-hmm. Or you might find that their coordination in terms of they just got poor body awareness is probably one way to look at it. And so from my perspective, that's probably most important if I'm trying to get them to do an exercise to, say, strengthen their hip, and they're struggling with coordinating how to engage their hip muscles, for example. So you might do a standing hip abduction, and they try and do that, and they feel a lot of load in their knee, and they're using their lateral quads and lateral hamstring instead of their gluteal muscles. So that's the sort of things I'd look at from a coordination perspective. And if they're struggling with those things, then we might spend a bit of time trying to work on that before we start loading them up with heavier strength stuff. Whereas if they can coordinate those things really well, then we can go into heavier strength stuff a bit sooner.
So you're just cooing them to try to help them perform the movement better.
Yeah, exactly. And most importantly, when you do give them those cues, does it actually help their symptoms? Because if you give them a cue to change what you think is a better biomechanical pattern and it makes their pain worse, then you're probably barking up the wrong tree. You want to maybe move on and think about some other things.
Yeah. And could you talk a little bit about the running, the retraining that you just mentioned? So like how you're trying to change a few things there. What are the things that you're trying to change and what you're looking for? You said that you want to see if the pain reduces right away, right?
Yeah. So I use a framework for doing my running assessments and retraining that I developed, and it's called RISK. And so I developed this. I like the concept of easy to remember things as part of the translation. So RISK is an acronym which stands for reducing load, which is the R, improving capacity is the I, shifting load is the S, and then keep adapting to the person in front of you is the K. And I'll talk through each of those, and it makes running and training make sense. So the reducing load, we can do that really easy in a runner by getting him to run less, get him to run slower. Someone with patellofemoral pain, we might look at getting them to do less downhill running because that can be really helpful in reducing load on the joint. So that's an easy option. It's not always an option that the runner in front of us wants to do, because telling a runner to run less is not always a fun job to do. Sometimes it's really essential in the short term. From a gait retraining perspective, there are strategies we can use to try and reduce load. And so the way I always like to think about it is there's strategies we can try and cues we can use, and there's the outcomes that they achieve. So if we focus on the outcomes that would reduce load, that's the key part. And the outcomes that would reduce load overall really comes down to where your foot lands relative to your center of mass. So the further in front of your center of mass your foot is landing, then the higher the impact forces that your body has to absorb. So bigger distance out in front of your hips, then more load, shorter distance in front of your hips, then less load. Now, that doesn't dictate exactly where that load goes, so this is something you can use for any runner, patellofemoral pain or not. The strategies that can help you to achieve that, to sort of shorten and get that foot under your body, you can use cues as explicitly as, I want you to try and land with your feet under your hips. I don't tend to find that works very well. For some people, it can be helpful. Step rate is probably the most common one that people use, so cadence, and so trying to increase step rate or increase cadence. So that's a strategy that some people use. Now, in some people, and those who have done it clinically, you'll realize that for the majority of people, when you increase their step rate, they sound a little bit softer. And if you do a video pre and post, they will land a little bit closer under the hips. But it doesn't always work. And there can be a couple of reasons it might not work. It can be that their step rate is already reasonably high. So this is really arbitrary and probably not that scientifically based. But I tend to find in the clinic, if they've already got a step rate of around 170, you don't have a lot of room to move. They've got a step rate of 160 or 150s, then you've got room to move. And so you might try and increase it by 5 or 10%. So that's a really simple, safe starting point. One of the barriers often to people being able to do it is they don't have hamstring muscle capacity. So if they don't have good hamstring muscle capacity, it's really hard to increase your step rate because you can't generate the power to bring your foot back under your body, and you can't shorten your contact time on the ground. It's just not feasible for you to do it. So if you're struggling with using a step rate cue, so trying to increase someone's cadence, I'd be assessing their hamstrings pretty quickly. I reckon that's usually what the barrier will be. So that's one option. And the other option I tend to find can be really helpful, and this is based on zero biomechanical studies that I've been able to find, it's just all from just playing around and learning from running coaches, is pelvic positioning. So if someone's really anteriorly tilted, it's a lot harder to engage and activate your gluteal muscles and your lower abdominal muscles and your hamstring muscle for that matter. So if you're finding someone's really anterior tilted and you can just shift into a little bit more posterior tilt, that can sometimes be a really effective way of reducing that overstride pattern. So again, reducing load. So they're the two main ones I'd look at. Now, there's probably other barriers to consider around pelvic positioning. It might be lower abdominal strength and core strength. It might be hip muscle flexibility, so they may be really tight through the anterior hip structures, a whole range of things like that. Could be weakness in the posterior hip, so gluteals, hamstring. So But there's some simple strategies. If we then move down to improving capacity and think about how does that link into gait retraining. So improving capacity, the first option, not gait retraining, is to just slowly increase your running volume and running speeds over time, and your body will naturally adapt to that. So giving the stimulus to do it. We might also get someone doing strength and conditioning work to increase their capacity. So we wanted to increase the capacity of your quads to absorb load. Well, let's do leg extensions and target. For the hip, let's do some hip abduction, hip extension, hip flexion, hip adduction, improve capacity of the whole hip. If we wanted to improve capacity of our calf to take more load, then we do heel raises, knee bent, knee straight, do some plyometrics, work on that. And so then we need to make sure that that transitions into actual running. So sometimes what you find with people is you might do all this great hip strength work, but they don't necessarily use that for the running activities. So you might actually need to cue them to do it. So from a gait retraining perspective, you might need to couple doing strength and conditioning work of, say, your gluteal muscles with some cues just as simple as, I want you to squeeze your bottom as you run. And what we don't want people to do is to lock their glutes on and run really stiff. Like, that's not what we're trying to achieve. So if you ask someone to do that when they don't have good capacity through their gluteal muscles, that's what they'll usually do. They'll just lock on and be really stiff. If you can work on building their strength and rate of force development through some good exercise programming, then you give the cue of trying to squeeze your bottom. Usually they just physically start doing it and it just comes a bit more natural to them. At least that's my anecdotal experience with it. So that's the I, improve capacity. And then shifting load can be a really useful strategy. So the most common thing that people use clinically is changing strike pattern. So going from a rear foot strike to a non-rear foot strike. And we know, for example, that can on average reduce load through the knee by around 20%. So it's a reasonable change. But the S and the shifting load is probably the one that I'll use most cautiously, because you don't make load magically disappear. So unlike reducing load, where we're reducing those impact forces, getting someone landing closer into the hips, if we do something like change strike pattern and shift load, the load will then have to go through the foot and ankle. And so that's where we can potentially cause new and other injuries. And I'm sure any clinician listening in has seen someone have a stress fracture or an Achilles issue or some other foot and ankle issue because they've changed their strike pattern, or they've gone to barefoot running or something like that. So that's something that needs to be thought about really carefully and really cautiously. And first question to ask yourself is, do I need to actually do that, or can I work on some other strategies and they're going to be enough? And if I do really want to do it, so maybe you've got someone with patellofemoral osteoarthritis and you really want to change them because you want to try and reduce the load there in the longer term, have they got the calf capacity? And if they don't, how do we develop that over the coming months? And that speaks to the K of keep adapting to the person in front of you. So in the short term, maybe all you do is work on step rate and maybe some pelvic positioning. In the long term, you might then change strike pattern. But before you do that, you might spend 3 months or 6 months or longer building up capacity to do that. So doing some calf work, working into plyometrics, doing that. And then the other element to K, when we think about keep adapting, you got to think about the person's goals. So most people come to us when they're 4 weeks out from a marathon, sometimes 2 weeks out. If we're lucky, we maybe get 6 or 8. It's usually not long enough to make any gross changes to their running mechanics. So you might not be doing any of this when you first see someone, but you're setting the scene, having conversation with them. Look, in the longer term, these are some things that might help. We might play around with your step rate now because it's nice and safe and easy to implement. Post this marathon, when you've recovered a couple of weeks later, let's come back. You've had this persistent knee pain for the last 5 years. It keeps coming every time you build up towards the end. We can see this with your gait mechanics. If we change some things, we might be able to stop this from happening to you so much. So let's work on your gait mechanics in that next 6-month block you've got before the next marathon.
And it's interesting that you said that some things got absorbed a load. So you have to be watching other body parts that you might be overloading and watch, the cost benefit of the changes you are.
Absolutely. Our job in medicine is first do no harm. So always keep that in the back of your mind. Don't make a new problem trying to fix one.
Yeah. And what was the last one? Is the goal? You said reduce load, improve capacity, shifting loading,
and then keep adapting to the person's needs. And so that comes back to, when do they come to you? So if they come to you 2 weeks out from their marathon and they've got a sore knee, you're not going to do much gait retraining with them. You're not going to do much strength and conditioning with them. You might do a lot of hands-on therapy, and you might do some taping and do a whole range of things to get them to the start and finish line. Whereas someone comes to you if they're 6 months out from their race, then you can start to do a lot of these things. So, and then it goes back to that thing about keep adapting. It might be that you want to change their strike pattern, but they need to do a lot of work before they do it. So,
yeah. Okay. And like regarding treatment, on those guidelines, they always mention a lot of different things. So I don't know if you want to briefly mention the things that you would do and things you would not do.
Yeah, sure. So I don't think we should ever put a blanket rule of don't do these things. The thing goes back to first do no harm. That's probably the key thing. So are treatments harmful? So some things I can think about for patellofemoral pain that could be harmful. So we want to maybe rule out and try and avoid at all costs. Arthroscopy surgery, it's a trauma in itself, which could actually accelerate the progression of osteoarthritis in the future. So we try and avoid this at all costs. Now, there is the odd person that I would send along who has patellofemoral symptoms and other things going on for arthroscopy surgery, and it might be we find out they've got osteochondritis dissecans, so that basically the cartilage is kind of in a dying state, and sometimes surgery and microfracturing and things like that can be helpful. It's not very common. Maybe there is a cystic formation somewhere that is really just irritable in the joint and really causing some of the issues, and we've done all the things I'm about to talk about in a second and they're not doing well, then maybe we consider that. But we're not going to go down that pathway in the early stages. Injection therapies, so cortisone, we know that has a detrimental effect on cartilage health, so try and avoid that wherever you can, unless you've got that marathon runner who's been training all their life and they're about to go to New York, and this is a common example I see. They're going to New York to do this marathon, and a cortisone will get them there and get them to do it. And it's something they've been dreaming of for the last 10 or 15 years or longer. We might consider that, but ideally we avoid it because of the potential iatrogenic effects of cortisone. Other injections like PRP, so platelet-rich plasma, they're a bit hit and miss. I don't tend to find them that helpful for this population. Some people will try them and think they're great. Synvisc, similar-ish, maybe get some slightly better outcomes with Synvisc in more athletic populations in the short term. But then there's a risk of infection and other things we've got to consider. So ideally we avoid these things if we can. And the other thing is the cost of these injections too. So they can be quite costly. So you've got to weigh that up. So they're not going to fix the problem in the long term. So they're only going to be a short-term solution. Pharmacotherapy, get them to always talk to their GP. And I'm not a medico, so if you're a physio or a physical therapist practicing, your job is probably not to prescribe anti-inflammatories or injections or things we've been talking about for that matter. So if someone's thinking about anti-inflammatories, always work with a medico as part of that, because there may be other health things you need to consider. But certainly anti-inflammatories in the short term can be helpful, but it's not going to fix the problem. So again, I'd not be jumping to them. And then if we move down to what can we do as physios, or physical therapists or other allied health clinicians, the great thing is we have lots we can do, which is really nice. So if I start with what do we have good evidence for, we have really good evidence that exercise therapy can be helpful, and that's hip and knee exercise particularly. And so I think not just giving a recipe approach, but actually tailoring the program based on your assessment, you're probably going to get better outcomes. We don't have good trials to support that, but that certainly makes logical sense. But regardless, if you could give a good exercise program, that could be beneficial. I would expand and always look at the foot and ankle as well. And I'd also look at the trunk and the core. And often my programs would entail that. So not just the hip and knee, which is where the evidence kind of lies. We'll come to patient education in a second. So education on load management and a whole range of other things. In short, we don't have good randomized controlled trials to say that education is of value. We do have some trials when you pull them together which compare patient education to exercise therapy, that there may not be a lot of difference in outcomes. So you may be able to get similar outcomes from a good quality education provided by you as you might get with exercise. You probably get better outcomes with both. If we look at adjuncts you might provide alongside your exercise therapy, taping is certainly effective in the short term, and there's a couple of RCTs that show that. In the longer term, doesn't really make any difference. So it depends which systematic review you read as to whether you think taping helps, because if they look at longer term outcomes, they'll say that taping doesn't help. If you look at the more immediate short term over the first few weeks and you tailor your taping, so by tailor I mean you're not just whacking a piece of tape on and hoping for the best, you're actually trialing a few things. So you're trialing some glide of your patella, you're trying some rotation of your patella, you might do some fat pad offloading. When you actually tailor it, it can be very beneficial in the short term, and the evidence supports that. But long term, it's not going to fix the problem. So use that as an adjunct to help get people engaged with exercise, get them through their run, get them through whatever exercise they're doing. If we talk about foot orthoses, so shoe inserts, the evidence is pretty good that they are helpful for some populations, probably less so in a running population based on the evidence we have. So Jason Bonacci did a nice RCT, small study of 8 per group, and showed that probably doing a gait retraining type intervention to increase step rate and shift some load by wearing some Vibrams for some of the run would be more beneficial than an off-the-shelf insert. But for more sedentary populations, when we look at those, off-the-shelf inserts can be really helpful in the short term. And the estimates of number needed to treat, so that's how many people you would need to give an orthotic to see at least one person have substantial benefit, is somewhere between 2 and 4. So typically, I don't know, different parts of the world, they'll cost different amounts of money. But here in Australia, a pair of shoe inserts off the shelf is probably going to cost, even if you add a 50% markup to what it costs you in the clinic, probably going to be cheaper than a consultation with a physio. So it's pretty inexpensive and a good option to try. And then if we talk about, I guess, things like manual therapy, massage, mobilization, those sorts of things, if you look at the evidence, there is no good evidence we can hang our hat on that they help in any way, shape or form with actually improving outcomes, whether that be in isolation or in conjunction with exercise. I guess what I'd encourage people to think about there is that doesn't mean they won't help in the immediate term, probably similar to taping. And so what I'd encourage you to do is think about using those things in a small amount rather than spending your 25 minutes of your 30-minute session doing manual therapy. You can usually achieve a lot in 5 minutes, and do that to try and help someone to engage better with exercise, reduce their pain while they're doing their exercise. And then if you find something that's helpful, don't keep them coming back to you for that manual therapy. Think about how they can actually do that themselves at home is really helpful. So you might do some soft tissue work on the lateral quads and suddenly they can load their knee a lot better with a leg extension. That's great. Can they do something similar themselves at home, using a roller, doing their own self-massage, using a Theragun, whatever it might be. So you could get them to think about doing some of that stuff in the short term. Things like dry needling and acupuncture, it's probably a similar thing. They can be helpful, again, in the short term. The evidence doesn't really stack up to support that we should use them and fund them, but some people will swear by them, find them helpful. It comes back to what we talked about before of potential benefit and potential harm. There's not really a lot of potential harm for dry needling, for example, unless you're doing lots of it and making the person reliant on you when you're losing time for doing the exercise and education part. So again, you consider using it, and I do use it with some patient populations, but it's not my first go-to. I rarely do much of this stuff in the first session. It's usually something we say, we can try this next time. The thing that probably we need to focus a lot on is education. And I say that because if we want someone to improve and manage their loads better and engage with exercise and do all the things that we know can be helpful, then we need to really educate them so they understand why that is the case. And that education takes a two-way interaction. So it can't be education when you've got them laying on the couch and doing massage and they're just thinking about that. You actually have to have a conversation and a meaningful conversation with them, understand their beliefs. So for some people, it'll be lots of education, like the adolescent who's just doing too much exercise. So you'd be writing out what training sessions they're doing, what games they're playing. So patient I had yesterday, I think they were training 4 times a week for football, so Australian rules football. They're training once for basketball. They're playing 2 games of football and playing 1 game of basketball every week. So the question I ask them is, who's your favourite player in the AFL? They tell me who their favourite player is, and I say, well, do they train that much and play that much? No. Are they growing? No. So do you think maybe you might be doing too much, and then you've also got this problem that you're growing at the same time, and you've got to have that conversation with the parents and with also the coaches, etc. So that can be important. It might be the runner who's just doing too much training, not having enough rest days, not doing some strength work alongside their training. So you might have to educate on that. For other people, they're so fearful of doing exercise. It's the opposite. They're worried about damaging their knee. They don't want to load it, so they don't want to engage in rehab to improve their quad strength. And so you need to spend a lot of time talking to them about how load is actually good for cartilage. It helps maintain cartilage health. pain is not related to damage in most instances. Pain is an alarm system and you can become really sensitized. And so we need to challenge your brain a little bit and get you to do some loading. If your pain flares up for more than 24 hours, then we might have to back off. But if it settles down quickly, we can keep incrementally increasing what you're doing with exercise. So there's two ends of the spectrum. It might be educating someone that, the massage work you're doing and the dry needling work you're doing is helping you in the short term. It feels better for a couple of days, but maybe it'd be better if we actually regain some muscle strength in some other areas so you stop overloading those lateral quads and lateral hamstrings and you keep getting all the soft tissue work done on. Why don't we do some work to strengthen your medial quads, strengthen your hamstring, strengthen your hip, and then that will usually reduce your need for all that manual therapy. So having those conversations individualized with people. Go back to what I said earlier, there's no evidence that is a beneficial thing. There's no evidence that if we jump out of a plane and wear a parachute that we survive. So I think we have to think through things logically. And I think as a clinician, if you're finding something helpful, it's low cost and it's helpful for the person's general health and well-being in the long term. So things like exercise, that's great. If you're finding some things that are helpful, but there's also associated harms, then your threshold for implementing that is much higher. So go back to the point of manual therapy versus active therapy. So manual therapy, you become very reliant and very passive, whereas more active therapy, hopefully we can get people to do that by themselves. So that's where my bias lies. And it's broadly supported by what the evidence tells us too.
And like in your experience in practice, do you see any patterns of like strengthening, like areas that are weak that you work more on strengthening?
Yeah, so definitely. I think really commonly we'll see proximal strength work will be helpful. And if you look at the literature and the evidence, it's pretty much guaranteed that if you have patellofemoral pain for longer than a few months, you're probably going to have hip muscle weakness. And you can make lots of biomechanical rationales, which I'm sure you've covered at different times, I'm not sure, but essentially thinking if you've got weakness in the hip, you may not have as good a control of your femur. That might put more load on the patellofemoral joint. The other really simple thing to think about is if you've got weakness in the hip, you're not going to load absorb at your hip as well, which means more load on the knee. So those could be two mechanical rationales for why you want to address the hip. So that's a really common area that I'll work on, both in non-weight bearing and weight bearing. So a lot of hip strength work. Hamstring for runners in particular, and that's often neglected. We often think of patellofemoral pain and we think of our medial quads and strengthening that, but we don't often address the hamstring. But there's actually good evidence that there's hamstring muscle weakness and loss of rate of force development in the hamstring. And for a running population, going back to what we were talking about before, where someone might be overstriding, landing further in front, addressing that hamstring muscle impairment can be hugely important for that population. Thinking about the calf, and so same concept as the hip, we want to be able to absorb load both proximally and distally so we can reduce load on the knee. So calf strength work can be really important. And so gastrocs are upper calf, so think about straight leg growth. So straight knee heel raises, that can be really important for gastrocs, and the gastrocs works really hard when you're landing. So jumping activities, sprinting activities, gastrocs is really important. But we don't want to neglect or forget about soleus, so thinking about your lower calf. And so that's going to be more targeted during bent knee activity. So think about running and think about mid-stance of running. Your soleus has to work a lot harder during that part. And so if your pain and symptoms relate to deeper squatting activities, mid to late stance of running, those sorts of things, and soleus can be really important. And so you often need to target that specifically with rehab. So bent knee heel raise, or ideally, if you want to target it in isolation, you go to doing more so a seated heel raise. So depends what you find. And I do see some commentary on social media that you should just do heel raises. You don't need to do bent knee. You don't need to do seated because soleus will work anyway. But it's actually not the case. You'll pick this up a lot in people. So you might do a straight leg heel raise with them. And I tend to look at a benchmark of close to a fifth of body weight for doing a 10 RM. So if you weighed 80 kilos as a simple example, you're going to be needing to get up to around 18 kilos for a single leg heel raise. If you then do that with your knee bent and suddenly you can't do 5 kilos, then that's a good sign. Or we might also do a seated heel raise, and we've done some work in Achilles and we want to see that getting up closer towards the 1.4 body weight. And maybe you do a seated heel raise and they can do maybe only half their body weight is in some instances patellofemoral pain. And that's a sign you're it's an impairment that you might want to address. Now, if you assess that and you're not picking up a big difference between knee bent and knee straight, then it may not matter. But if you're picking up those differences, then I'd hone in on that a little bit more.
Yeah. And like in terms of progressing load, I remember you mentioned next day they cannot be sore, right? So how do you progress load? You just seeing if they tolerate well on the next day?
Yeah, so load from a knee perspective, and that might be running volume, it might be how many stair repetitions they do, for example, as an activity. Ideally, you see your pain settle within an hour or so. That would be good. So a little bit of pain during is okay as long as it's not increasing, and ideally it settles within an hour or so. But the key telling time point is that 24 hours later. So most people with persistent knee pain have persistent knee pain. So we don't expect them to be pain-free the next day. What we want to happen is their day-to-day symptoms aren't any worse. So if they normally get a little bit of pain walking downstairs, we need to make sure that that's not any worse the next morning. And if that's the case, we can progressively increase how much running volume they're doing or what else they're doing. And then from an exercise perspective, we can follow pretty similar. And so for a lot of exercise rehab focused proximally, you can do things that don't really load the knee. So you might, whether that be side lie hip abduction, standing hip abduction, bridging activities, you can do those without loading the knee too much. So often in the early stages, if someone's got a really irritable knee, I'd focus on that and then bring in the knee loading later. There is a little bit of evidence that would suggest if you target proximally in the early stages rather than the knee, you might actually get slightly better outcomes. In the long term, we need to do both. And then when you say bring in your knee loading, and so knee extension is a really common one that I use, and it's often can be very provocative too. So it comes with risk, and I always talk to the person when we start doing it. I say we're going to do knee extension, will often start statically because it's less likely to irritate symptoms. In someone with patellofemoral pain, we might do that at around about 45 degrees because as we go closer to the terminal extension, we'll often irritate the joint. We'll trial it. We might do, say, 3 sets of 30 or 40 seconds at a reasonable load, see how it goes the next day. If it feels good, then we slowly try and increase the load. And then at some point, in a couple of weeks' time, we might go to dynamic. So we might do a leg extension exercise that goes from 90 to 45 degrees, and we might do 3 sets of 10 or 12 at a reasonable load. And then again, we monitor the symptoms and see how it goes. And then if that's going well, a few weeks later, we might try and do some more targeted rate of force development stuff. So trying to increase that. So we might actually start to do a faster movement up and slow on the way down. And so the whole time we're progressing our load, whether it be running or daily activities, or if we're progressing our gym load, it might be going from static holds of muscle contraction to dynamic to rate of force development, or it might be increasing loads. And we just use that guide all the way along as to whether we're doing too much too quickly. And if I always say to a person, at some point, you're going to stuff up and you're going to do too much too quickly because you want to do it. You're going to go for a longer walk or a longer run, and your pain's going to last for 2 or 3 days because it's going to be acutely inflamed, and I'm going to forgive you. We're going to work together and we'll sort it out. And I say there's a very good chance, and hopefully it doesn't happen very often, but it does occasionally. There's a very good chance I'm going to give you a new exercise or a new activity, and I'm going to stuff up. And you're going to let me know, and you're going to forgive me, and we're going to work through it together. And I think setting that expectation that it's okay to have a pain flare is really important.
Yeah, absolutely. And like regarding the body weight, the amount of like the load that you mentioned, like those standards, is there any way that we can look for that and search that? Is that like in a paper or what?
This is not really based on anything scientific. So this is very much my anecdotal reasoning. So if I go through them just as a list, so essentially I'm looking at heel raise activities. I'm usually going for a fifth of body weight. So that's thinking about foot and ankle. At the knee, leg extension, working that 90 to 45, I'm looking for half body weight. Leg curl, I'm looking for about a third. If I go up to hip abduction and hip extension, I'm looking for about a fifth of body weight. And then if you want to move more proximal, it's a bit hard to do body weight stuff with, say, a plank exercise. But those who have TheraBands, if you can get to the point where you could, say, do a side-lie plank, and you could use, say, a green or blue TheraBand and do a 10 rep of that in a side-lie plank in a good position, that's showing you got pretty good strength proximally as well. I go heavier than that, but that's just some rough benchmarks. And that's not based on anything science or research papers. It's more based on what I'll typically see in more athletic populations. When they get to those points, they're usually pretty resilient to do most things.
Yeah. Okay. I know we have to wrap it up. So Just one more quick question. Resource of information, anything you recommend people to go look for if they want more information on this topic?
Yeah, so I guess really strong recommendation on the patellofemoral topic to go to the TREC site. So trekeducation.org, and there's actually a patellofemoral site within that for clinicians. So there's clinician sites, and there's also a site called My Kneecap, which we've developed over the last few years for people with patellofemoral pain. So those two resources should help you and also help your patients. And on them, there's lots of research papers linked, there's infographics, podcasts, and in the patient site, there's actually some nice simple exercise videos. So you can, of course, give your own exercise and things, but sometimes that's a nice little basis of a little program you can try and give people.
Awesome. And on that GLAD program that we haven't talked about, the arthritis, I found like a PDF. Is there like something that PTs can access to see the exercise? Is that open, available, or yeah?
Yeah, so at the start of the pandemic, Soren Skue and Eva Bruce set this up in Denmark a number of years ago, and then we've adopted it here in Australia, and it's quite a widely used program. At the start of the pandemic, I worked with Soren and we set up some exercise videos that are used in GLAD. So I guess I have to stress that's not GLAD, because GLAD includes education and a range of other things, but the actual exercise program, the core of it, there's a site called NEMEX. And so again, if you go to trekeducation.org, there's a link in the clinician site section, and there's the NEMEX site there, and that's got essentially all the exercises and many of the progressions and things. So it'll give you a basis to see what the exercise program's all about. And I think on that site too, there's also some research papers related to the development and evaluation of GLAD as well.
Yeah, I found the PDF. I just want to confirm if that was the program. Great. And if people want to find you or contact you, is there any way they can reach out or find more information?
I haven't been as good with social media last couple of years for various reasons, but I am on X, formerly Twitter, so at Dr. Chris Barton. That's probably the easiest. If you have any questions, happy for you to email me, which my email address is c.barton@latrobe.edu.au. And then if you Google Complete Physio Richmond, that's the clinic, and we have courses and PD and things there for anyone that's in Australia or Australian-based. Or if you want to do courses overseas, I haven't been over for a while since before the pandemic, but in the past have been to many places around the world, so I'm very happy to chat to you about coming out to do something overseas at some point, so just get in touch.
Awesome. Thank you so much. This has been great. A lot of information to unpack, so it's been awesome. Thank you so much.
My pleasure. Thanks so much for having me.